This next chapter, or next part of chapter 15, is going to be all about the injuries that occur in the shoulder. It's not everything that can happen to the shoulder, but we'll go through the primary things. What we're going to see, the mechanism of injury, the primary signs and symptoms, and we'll mention the special tests that are often used to help diagnose. So starting off here, we have our sternoclavicular joint sprains, or SC sprains. These are not overly common. They do happen. When they do happen, they are fairly painful. If you guys remember that there are 4 joints that make up the shoulder complex: the SC joint, the AC joint, the scapulothoracic joint, and the glenohumeral joint. All those joints have to work together in order for us to have full shoulder mobility. So at the SC joint, there is a lot of pivoting and rotation that occurs whenever we're doing any kind of overhead motion, especially overhead motion with any kind of internal or external rotation. So very painful for any kind of overhead throwing athlete if they have a SC sprain on that side. If you remember the anatomy, you have the clavicle, which is very round at the end, sitting in the clavicular notch of the manubrium. So we have a very round structure sitting on a very skinny structure. We also have that disc in there, and then we have our wrapped all the way around. You have your anterior and posterior SC ligaments. A couple others that are also there to keep the joint in place. But it is a relatively strong joint, even though there's not a ton of bone-on-bone contact. The way that this is going to be injured is primarily through a longitudinal force. In this foosh, we call it the foosh mechanism. It is falling on an outstretched hand. Is your foosh mechanism. And that could be falling on an outstretched hand. It could be falling on an outstretched elbow. A big one we see when it comes to SC sprains is falling on the tip of your shoulder. All that is going to cause a longitudinal force to travel down your arm, through your humerus, through the glenoid fossa, transfer that force down to the clavicle, and the force is going to continue down to the clavicle until we get to the SC joint. One of the reasons the SC joint doesn't sprain all that often is because when we have this foosh mechanism, the weakest structure is going to give first. So sometimes when you fall on an outstretched hand, your wrist breaks. Sometimes your forearm breaks. Sometimes you dislocate your elbow. Sometimes your humerus breaks. Sometimes your humerus dislocates. Sometimes your clavicle fractures, or your AC goes, or sometimes the force travels all the way down your arm, all the way up your arm, and then all the way down the clavicle, and then finally we see the SC joint as the weakest link, so it is going to break. So again, not near as common, but when it does happen, it's pretty painful. The longitudinal force, that foosh mechanism, especially falling on the tip of your shoulder, is the most common. We also see a traction force. Traction meaning pulling the arm away from the body. So when you pull your arm, you pull the glenohumeral joint. The glenohumeral joint is attached to the scapula. The scapula is attached to the clavicle. So when you pull the humerus, then the scapula can pull the clavicle, and it ends up pulling the clavicle away from the SC joint. Not very common because it's a strange kind of mechanism. Where you would see a traction injury the most would be in gymnasts when they are flipping and grabbing the bars or the ring, when their full body weight is coming down and their hands are catching them overhead. So that's when you tend to see the traction problem. But most of the time in traditional sports, we're going to see the longitudinal force. When someone does sprain their SC joint, you're going to have pain over that SC joint. So just like any other ligament sprain, you have pain over the ligament. So it's very point tender type pain. We're going to have pain with scapular protraction and retraction. We're going to have pain with any movement over 90 degrees of elevation, especially when you associate that with internal and external rotation. When you actually palpate it, it's going to be very point tender, but if they move it, you might actually feel crepitus, or that creaking, crunching sound, feeling underneath your fingers when you do palpate. And the person may present with their head tilted toward the injured side with their chin away. We haven't talked about this muscle, but the sternocleidomastoid actually has sternum. It's going to have attachment on the sternum and on the clavicle. So the sternocleidomastoid has an attachment here and an attachment over here, and then it inserts on the mastoid process behind your ear. So because of where that muscle actually inserts, when we contract that muscle, it's going to cause pain at the SC joint. So if you tilt your head toward the injured side, it actually relaxes the sternocleidomastoid, so that, that muscle won't be putting pressure or tension on this joint, causing pain. Um, SC joints can also be dislocated. Most of the time, what we see is an anterior dislocation, so they're 10 times more common to happen than a posterior dislocation. So if we do dislocate the SC joint, it should be pretty obvious. It'll be an obvious deformity, especially if it's anterior. It's going to be sticking out even more than the other side. So those are the most common. It's going to have the same kind of mechanisms, just with even more force than a regular sprain. It's got to be enough force to actually dislocate it. We can also have superior ones. Those are not as common. And we can also have posterior ones. These posterior ones are, your example is going to be down here, is a posterior dislocation of your clavicle. That's actually a big problem. It can actually be considered a medical emergency. We have very, very important structures that sit right behind the manubrium and the clavicles, and when the clavicle is displaced posteriorly, it can actually impinge those things. So, for example, we have the subclavian artery and vein. The subclavian artery and vein, well, the subclavian artery comes directly off of the aorta, so it carries all the blood flow to that side of the upper extremity. So the right subclavian artery carries all the blood that's going to be going to the right arm. The vein is going to travel with that. Also back there, we have our trachea and our esophagus, so it can actually close off your windpipe or your esophagus, not allowing air to escape or to get in. So posterior dislocations, again, not very common, but if they do happen, you have to get that. It's a medical emergency. You have to get them to the hospital quickly. Some signs and symptoms of the actual dislocation, especially if it's posterior: dizziness, nausea. There could be some neurological symptoms, dyspnea and dysphagia, shortness of breath, and I think inability to swallow are going to all indicate that that's a posterior dislocation, and it actually is impinging something very important when it is dislocated. So when we have an actual SC joint injury, we need to make sure that we actually know what's going on. Your clavicle is one of the last bones in your body to have the growth plates actually heal all the way. So the medial epiphysis on the clavicle does not fuse until about 25 years of age. So in the majority of the population that we work with, those people are not going to have a fused epiphysis on their medial clavicle. So we have to make sure that we understand what's going on here, that it's not a regular dislocation or regular sprain, but we identify that it is actually a fracture, a Salter-Harris fracture of the growth plate at that medial clavicle. So it's called a pseudodislocation, where we have a fracture of the growth plate that's displaced versus a regular dislocation. So it's going to look very similar, except for there will be this bump still hanging out at the SC joint. The signs and symptoms are going to be very similar, but either way, we're going to want to refer that. So if in the grand scheme of things, yes, you want to know and try to differentiate a dislocation that's regular compared to a epiphyseal fracture, but in the grand scheme of things, either one is going to be sent for treatment. It's not necessarily a medical emergency unless it's posterior, but they do need to go to the hospital or to the doctor to get that thing, to get it looked at. Generally speaking, for a sprain, we use palliative care, which is just kind of your general care. No real doctors and stuff are needed. No surgeries are needed. Depending on how severe it is, you might send them to a doctor, but maybe not. Do your general rice, put them in a sling, because remember, the entire upper extremity is attached to the axial skeleton by one joint, and that joint is the SC joint. So you want to make sure that you have them in a sling that takes some of that tension off of the SC joint when it's healing. When it comes to dislocations, you need to send them to the doctor immediately so they can get it reduced, and then again they'll be immobilized with a sling. If it is a posterior dislocation, there's very good chance they're going to have surgery, because we cannot risk a continued or a recurrence of a posterior dislocation, because that's a big problem. Okay, so the next one out is going to be your AC sprain. We actually skipped clavicle fracture because it's a fracture, so those are dealt with. They're pretty straightforward. When you have pain directly on the clavicle, it could be displaced, point tenderness, obvious deformity, a lot of swelling. Generally, a clavicle fracture is going to be from a Fuchs mechanism, so longitudinal force, or from direct contact, but they're pretty easy to recognize. When they become a little bit more difficult is when their fracture is closer to the AC joint or the SC joint. Like the pseudo dislocation was your epiphyseal fracture, that's going to look like an SC joint sprain. We can also have clavicle fractures that occur very distally, close to the AC joint, and sometimes you might get those confused with AC joint sprains, but in reality they are clavicle fractures. The way that you fracture it is going to be basically the same way that you would hurt your AC joint. So again, the mechanisms are relatively similar. When it comes to the mechanism for the AC sprain, similar to what you're going to find with the SC sprain, that Fuchs mechanism, falling on an outstretched hand, outstretched elbow, but more specifically, falling on the point of your shoulder. So whatever is going to happen is going to end up driving the scapula posterior to the clavicle. So we have the scapula come up, and specifically part of the scapula we're talking about here is the acromion process. So the scapula is going to come around to the acromion. Then we're going to have the clavicle sitting on top of it, and that's where your AC joint is. So whatever the Fuchs mechanism, when you actually fall on your hand or your elbow, it's going to the force is going to travel up the humerus. The humerus is going to drive into the glenoid fossa. The glenoid fossa is part of the scapula, so that's going to drive the scapula medially. So when this comes in, it's going to actually drive it that way, and taking the acromion with it, where the clavicle stays put, so they're going past each other, causing an AC sprain. So that can happen from a Fuchs mechanism, but it can also happen if you fall on the tip of your shoulder. So when you fall, it happens a lot in football. And again, it's how clavicle fractures occur in football. Say you're a running back or you're the quarterback, and you're trying to hold on to the ball, so you're not able to break your fall with your hands, and you get tackled and driven into the ground with the point of your shoulder getting driven into the ground. In that case, instead of the glenoid fossa getting pushed, the acromion is actually getting pushed because you landed on the very tip of your shoulder. So your acromion is getting driven this way, and again, your clavicle is staying put. So at the AC joint, we actually see that separation. AC joint sprains are also called separated shoulder. So when you listen to general commentary about injuries, when they say separated shoulder, they're talking about an AC sprain. So that's very common injury. There are different grades to this injury. We're going to have basically 3 different grades depending on how many structures are going to be involved. A grade 1 is going to just involve your AC ligaments, your acromioclavicular ligaments. You have your superior and your inferior. A grade 2 is going to be a complete rupture of the AC ligaments, but your coracoclavicular ligaments are still intact. A grade 3 is a rupture of the AC ligaments and a complete rupture of both of your coracoclavicular ligaments. The worse the grade, the higher up the clavicle can actually pop. So grade 1, we really don't see much clavicle displacement because we still have the structures holding the clavicle into place. Grade 2, we start to see some displacement of the clavicle where it sits a little bit higher because the AC ligaments are completely ruptured, but we still have our coracoclavicular ligaments. In a grade 3, we don't have any ligaments there holding down the clavicle, so we actually see a displacement of the clavicle. It actually pops up a little bit higher. When someone has this problem, we're going to obviously have pain over the distal clavicle, so where the structures are, that's going to be a lot of pain. Pain at the AC joint, obviously. We might see some pain around the superior scapula and the lateral deltoid. So it might be important tenderness. It might just be dull, diffuse pain. That step deformity is the idea of this displacement. So we tend not to see a step deformity, a step off, when we only have a grade 1. We'll see a minor step off, but not really for a grade 2. But a grade 3, you can see that this clavicle is actually sitting higher. So like a grade 2, a high step off would be all the way up there, and that doesn't really happen. But your clavicle actually moves and is sitting higher. You can see it through the skin. It is a very obvious deformity. You can feel it under the shoulder pads. You'll know you'll have that. The piano key sign is technically, I guess, a special test. But for the piano key sign, all you do is you see this clavicle sitting up. You push down on it, and if it pops back up, that's a positive piano key sign. So not an overly detailed type of test. Just like the SC joint, we're going to have pain with active and passive range of motion above 90 degrees. Anything overhead is going to cause a lot of pain. We're especially also going to have pain with horizontal adduction. When you bring your arm into horizontal adduction, we see this AC joint having to pivot because your scapula is going to come around into protraction. So that's going to cause a lot of pain. So even grade 1 AC sprains, although they're not displaced, they're not that serious, they actually do cause a lot of pain, and everything over that you do with your arm above your head is going to hurt. So even in athletics, although the joint is stable, you tend to be out for a while until that pain is gone, because there's really not much you can do until it fully heals. And when we see this, range of motion is going to be diminished in all planes, so especially over 90 degrees. Anything below that, you're not going to see much difference in the range of motion, but anything that really stresses the scapula and at the end ranges of any range of motion, you're definitely going to see a decrease. Here's what I'm talking about with the step deformity. Normally the clavicle is going to come straight down here and insert at the acromion down here. In this case, his clavicle is sitting all the way up here because he tore not only the superior and inferior AC ligaments, but also the corticoclavicular ligaments. So now there's nothing holding this in place except for fascia, so the clavicle is sitting up a lot higher. So that's an example of what a step deformity would look like. And your piano key sign, all you would do is you take the clavicle, you'd push it down, and then see if it comes back up. Like I said before, there are different grading scales for AC sprains. We tend to focus on grades 1 through 2 and 3. There are 4, 5, and 6. We don't really talk about those, but they're just worse degrees of 3. So 3 is your complete rupture of your AC ligaments and your corticoclavicular ligaments. As we go down to 4, 5, and 6, then we start seeing fascia that's torn, possible the fascia that's attached to the muscle. There's also displacement involved, so not the displacement when I talk about it sticking up, but anterior, posterior displacement. Sometimes the clavicle can go underneath the coracoid process. That's bad news. So your 1, 2, and 3 is talking about how much ligament damage is involved. 4, 5, and 6 takes it even further than that and talks about other soft tissue damage and displacement. But what I care about is 1, 2, and 3. When it comes to treatment of the AC sprains, generally speaking, you're going to if it's hypermobile, we have a lot of mobility, you're going to refer to a doctor. If it's greater than a grade 2 sprain, a lot of times they will do surgery, just because it's sticking up so far that we have to do something to keep it down. Grade 1s and 2s, even if it is slightly displaced, they really don't do much about it. You will see people walking around with their clavicles sitting a little bit higher, but again, not much they really do about it. We do that palliative care, that conservative treatment. You'll be in a sling as well, because again, there's a lot of tension hanging from your arm. So if your arm is not in a sling, you'll have a lot of pain in the AC joint. Usually it's a 1 to 4 week healing process. It again just depends on how serious it was, but it is a relatively painful problem because anything overhead does hurt. Then you'll just get into your range of motion and your strengthening, and when the pain is gone and your strength is back, then you're able to return to play. The next one is going to be glenohumeral instability, and remember that instability is different than laxity. People in general can be lax. The sulcus sign just tends to test for just general shoulder laxity. When we look at the actual glenohumeral instability, instability is laxity that's now causing us problems. Where if you identify that someone has lax joints, it does not mean that they're actually injured. But in this case, we're dealing with someone who either does have lax joints and got injured, or got injured and resulted in laxity of the joint. So this could be someone who dislocated their shoulder, and because they dislocated their shoulder, they ended up having increased laxity now because the humerus went through the anterior joint capsule. So instability is the key thing here, and that's not glenohumeral laxity, it's glenohumeral instability. There's a couple reasons why our glenohumeral joint can become unstable. It could be a result of a ligament or labral pathology. If we look at the actual anatomy, again, we have the labrum that goes around the glenoid fossa. We do have, some of those ligaments on the anterior side, although they're not very strong. So, the labral tears or ligamentous problems / capsular instability can all result in a decrease in the static stabilization of the shoulder. We talked about how we have dynamic stabilization and static stabilization. Static stabilization is the bone, the ligaments, the fascia, the labrums. Those things are all static stabilizers. Then we have our dynamic stabilization, which is our muscles that are responsible for keeping our joint in place. So this instability can be caused as a result of poor static stabilizers, which would be your ligaments, labrum, and capsule, or poor dynamic stabilizers, which would be your muscles. Either way, it's going to end up resulting in instability. So in this, we see a giving away or subluxation of a joint during functional activity that causes pain and inability to complete the activity. Whatever is going on is now affecting our activity. It could be causing subluxation, where our joint actually leaves its surface and returns on its own. So again, this is worse than just laxity. This is the instability, where it's actually it's causing us pain. It's causing us to affect our activity. A lot of times we have anterior instability is the most common, generally as a result of a dislocation. Anterior dislocations are the most common, and with a dislocation, the humeral head leaves the joint surface, and if it leaves anteriorly, then we're going to stretch out the entire joint capsule because the humeral head is now pushing forward. The humeral head is not supposed to push forward, so it's stretching out the capsule as it leaves its proper joint surface. So when we do dislocate, we're going to come anteriorly, and generally we're going to come through the superior and middle glenohumeral ligaments. So if you remember, again, those are part of the capsule, so we actually stretch out these ligaments when we stretch out the anterior capsule. When we dislocate, we also see that we have some dysfunction of the rotator cuff. Obviously, if we're dislocating our shoulder, we have poor static stabilization, but if it continually happens, we also have poor dynamic stabilization. So if we are dislocating, that means your muscles are not working correctly. Your rotator cuff, which is responsible for keeping your humeral head in place, is not working well enough. So a lot of it's kind of a combination of your static and dynamic not working together, which is going to result in your dislocation. We also sometimes see dysfunction of the long head of the bicep tendon. It is also going to help, based on how it runs, keep your shoulder in place. And if it's not working correctly, then again, it's going to result in dysfunction or in dislocation. The primary mechanism of injury for anterior dislocation is going to be the 90-90 position. So he's lying down right now, but he is in the 90-90 position. The arm is in 90 degrees of external rotation, and your shoulder is abducted to 90 degrees. This is going to put the most risk on your shoulder. The 90-90 position is the position where people tend to be in when they get the anterior dislocation. When we're dealing with someone who actually has this anterior instability, they might have had a history of subluxation or dislocation. They might be lax in general. They might have poor muscle tone. But when they come in with their signs and symptoms, usually if they are in pain, it's that dull, diffuse, achy pain. They're not going to really be point tender anywhere, but they're going to report that they feel like their shoulder keeps coming out whenever they do the activity. They know what that feels like. They feel like it's coming out. And if it is definitely a recurring dislocation or subluxation, it might not even hurt them anymore. I've known people who are chronic dislocators who dislocate their shoulder without much force at all, and they're not even in much pain. They just say, put it back in, and it doesn't even really hurt. The first time you do it, it tends to hurt a lot. When we start doing our special tests and things like that, you will see an increase in anterior glide. So if he took his hand underneath here and pushed up, there would be an increase in glide. The humeral head would move off of the glenoid fossa, and you could actually feel that increase in glide. We also will have a positive apprehension test and a positive Job relocation sign. So remember the difference between those. The apprehension is when you're in the 90-90 and you go into external rotation and you go until they tell you to stop and you're looking for pain and apprehension. The Job relocation test is like what he's doing here, where he puts pressure on the anterior joint capsule, does it again. Remember that these two tests should be used together. The apprehension and relocation test should be used together. If we see an increase in range of motion in shoulder external rotation during the relocation test, so if we see more range of motion during Job, then that's a positive test for anterior apprehension. Anterior instability. So, I'm going to say it again. We're going to test apprehension. We're going to get a specific range of motion, and we're going to stop. Then we're going to put pressure over the anterior capsule, and we're going to test external rotation range of motion again. If during the relocation test we get more range of motion than we did during the apprehension test, then that is positive for anterior instability, because they're able to get more range of motion when your hand is acting as the anterior joint capsule. If your hand's not there, they're afraid they're going to dislocate. So that's a really good, test combination to do if you suspect someone has anterior instability. If the range of motion does not really increase between the apprehension and relocation test, then that person just has poor range of motion. We also see in these people, they tend to have decreased active, passive, and resistive external rotation. So external rotation is the at-risk position for them, and they kind of want to avoid it. So overall, we really don't see all that much in the physical exam, except for some of these special tests and whatnot, because they're not really complaining of all that much. But as soon as they do activity and dynamic movements, then they're going to have a lot of pain. Things that are going to be associated with anterior dislocation specifically. So when you do dislocate anteriorly, we tend to see two things. We have a Hill-Sachs lesion and we have a Bankart lesion. A Hill-Sachs lesion is technically defined as a defect in the posterior humeral head's articular cartilage. So what's going on here? If we look at this, find out where we're at here, these two muscles here are the rotator cuff. It's going to be the subscapularis and probably the teres minor or infraspinatus, either one. Here is the scapula, here's the glenoid fossa. The white part down here is your labrum. This whole part is your humeral head. Here's your greater tuberosity, bicipital groove, and lesser tuberosity. So over here is anterior, over here is posterior. This is the normal positioning of the humeral head. So we have muscles pulling from the front and back, keeping the humeral head on the glenoid fossa. When we dislocate anteriorly, we have the humeral head pop off anteriorly. When that happens, not only do we have an anterior dislocation and a stretching out of all the structures in the front, we also end up we can get a divot on the back side, the posterior aspect of the humeral head, because it dislocated. And as soon as you dislocate, your body recognizes that your body is out of position, so it actually spasms. These muscles start to spasm, and they pull really, really hard. So your joint is out of place. You have articular cartilage along the entire humeral head, and now it's being driven into the glenoid fossa, which is kind of pointy. So you have a round humeral head getting driven into the pointy part of the glenoid fossa, and that's where we get that Hill-Sachs lesion. It's a defect in the posterior humeral head's articular cartilage. So with the anterior dislocation, the posterior part of the humerus is getting driven into the glenoid fossa, causing that articular cartilage lesion. The next one is a Bankart lesion. This is going to be a problem with the glenoid labrum. So again, looking at this picture, we're looking at it from the anterior side. Here's the biceps tendon. Here's your humeral head. So we're looking at it from the anterior part. When we have an anterior dislocation, we're pulling the entire anterior capsule forward. When that happens, oftentimes we pull part of the glenoid labrum with it. Because the capsule is somewhat attached to the labrum, if we stretch out the capsule, then we can also stretch out the glenoid labrum, and it can actually come off. So here's an example of a labral tear. I know we talked about the SLAP lesions before, but here's a labral tear called a Bankart lesion that's associated with anterior dislocations. So when the humeral head comes out the front and pulls the capsule pulls part of the labrum off of the glenoid fossa. So that was all about anterior instability. This next one is about posterior instability. Overall, posterior instability is very rare. About 3% of all shoulder problems all shoulder instabilities are posterior. The vast majority are anterior or anterior inferior. Part of it is the mechanism of injury behind how these things occur. Part of it is because the posterior capsule is a little bit tighter than the anterior capsule. But the mechanism of injury for this posterior instability or posterior dislocation is going to be a humerus flexed and internally rotated with a longitudinal posterior force. Now, if you think through what that actually means, and you look at this big guy right here, linemen are very prone to posterior instabilities because when they're blocking someone, they have a flexed humerus. Because they're grabbing someone, their arms are oftentimes internally rotated, and because some big giant person is running at them, there's a longitudinal force moving down their arm. So how you actually get these is exactly what a lineman does on a blocking basis. Every time they do this, they're putting pressure on the posterior capsule, possibly putting them at risk for posterior instability. This could occur with one big giant trauma, but oftentimes we see this posterior instability not really as a one-time posterior dislocation, but a bunch of micro trauma. So every time that they block, they're putting force on the posterior capsule, and it's loosening over time. So we see a lot of this with blocking in football. We also see some posterior instability. Sometimes it can kind of go either way, posterior instability or posterior capsule tightness when we do the follow-through motion after overhead activities. So whether it's tennis or volleyball or baseball, softball, when you're done throwing or whatever you're doing, the follow-through motion can actually put a lot of tension on the backside of your humerus. So when someone does have posterior instability, you generally have weakness of the subscapularis muscle. That's the anterior rotator cuff muscle. Its job is to prevent you from going backwards. So this person could have a weak subscap muscle. We could also see some of the weak glenohumeral ligaments. They're already relatively weak, but they could be even weaker. And again, the biceps tendon is there to help you keep your joint in place as well. They're going to have the same kind of symptoms as the anterior, where it's going to be more dull, diffuse pain. Everyday normal activity might not cause them pain, but as soon as they perform their activity, that's when they're in pain or in fear of dislocation. But usually normal life for these people is not too bad. The picture here is your posterior apprehension test, where you put the arm into 90 degrees of shoulder flexion. The examiner is going to feel underneath the shoulder and then push straight down and apply an axial load through the humerus. And the goal is, just like with the anterior apprehension, the goal is to basically watch their face and what kind of results you get, as well as feel for any kind of movement of the humeral head from the glenoid fossa. Like with anterior dislocations and instability, we saw the regular Hill-Sachs lesion. Well, in this case, it is a posterior or reverse Hill-Sachs lesion. So in this case, instead of having the defect on the posterior side of the humerus, we see the defect on the anterior side of the humerus. So what's going on there? Instead of the humerus dislocating this way, the humerus is going to be down here, and that's when we're going to see. So if the humerus dislocates posteriorly, it's going to be over here. So now we have a defect on the anterior side of the humerus. So it's just considered a reverse Hill-Sachs lesion because it's on the other side. But the traditional one is from an anterior dislocation, which is your regular Hill-Sachs lesion. Then we just kind of have general tests for glenohumeral instability or glenohumeral laxity. We have our anterior apprehension specifically for injury to the anterior side, our posterior apprehension specifically for injury to the posterior capsule. Then we just have kind of general tests. We have a sulcus sign. We've talked about this one in lab, but all you do is apply traction to the arm. You're going to pull the arm straight down, and here is your acromion, and then here is your big gap where your humerus that used to be sitting up here has now gone below. So it's actually sitting down in the fossa, halfway out of the fossa, which gives us this big gap. Get rid of these. This is um, not necessarily a problem. There's a lot of people who just have laxity, but the sulcus sign is going to indicate multidirectional laxity. So because it's multidirectional, it's not really a result of trauma, where we have anterior apprehensions positive because there's anterior laxity, but posterior is posterior. But in this case, the entire capsule is just lax, and it may or may not be an indicator of injury. However, these people, if you're just naturally a lax person, you'll have a positive sulcus sign, and you do decide to play overhead throwing sports, you may actually develop some sort of pain and injury. If you have this multidirectional instability, you're going to be at higher risk for getting things like shoulder impingement syndrome, just because you have more movement between your humerus and the rest of soft tissue structures. So positive sulcus sign does not mean that you are currently injured. It means you are lax. However, you might be more at risk for developing shoulder injuries during certain activities. And then different multidirectional instabilities, when is defined as 2 or more unidirectional problems. So these people are going to have laxity and increased range of motion, increased motion in general in multiple planes. We can also do a sulcus sign with the shoulder flexed to 90 degrees, and that's going to indicate we have an inferior instability. So these are all just ways to test for just general glenohumeral instability. Sulcus sign is going to give you information, but it's not going to necessarily give you any kind of diagnosis.